Ramya. We'll go on to the presentation from Medicine 3 from Dr. Hamsavardhini, Toffy trouble. Yes, when we're waiting for that, I think that head-to-toe examination is a very, very valuable tool, and you'll have to do it repeatedly. For some of the patients, you may have to kind of either see whether they're recovering from therapy or you need to diagnostic. So that head-to-toe examination is very important. I think Hamsas is coming on soon. Please go.
Good morning. I'm presenting from Medicine 3. My topic being Toffy trouble. Mr. S, a 35-year-old poultry farmer from West Bengal, presented with complaints of swelling of multiple joints for 4 years. These swellings involved bilateral wrist, elbows, knees, and ankle joints. They were intermittent with intermittent flares of pain. There was no history of early morning stiffness. The swellings were present over the dorsal aspects of the hands and legs, involving the shin, ankle, feet, and dorsum of the palm. There was occasional low-grade fevers associated with it. He also had weakness of upper and lower limbs for the last 4 months, which was acute in onset and worsened and occurred after following a fall in the bathroom. Initially, his upper limbs were involved, and after 1 month, his lower limbs were involved. He associated with this, he developed bladder incontinence, which was a recent onset, 15 days prior to admission. There was no history of loss of appetite, no photosensitivity, no skin rashes, no history of high-grade fevers with chills, and no history of surgeries in the past. Past and personal history, he was diagnosed with systemic hypertension 3 years ago and with hypothyroidism 6 months ago, for which he was on medications. He's a non-smoker and non-alcohol consumer, and there is history of intake of alternative medications for constipation. On examination, he was tachycardic with respiratory rate of 130 beats per minute. He was febrile, low-grade fevers with temperature of 100 Fahrenheit. There was pallor. There was a grade 1 pressure sore in the right trochanteric region. There were multiple subcutaneous swellings noted in the ear, bilateral legs involving the shin, the medial malleolus, dorsum of the hands and the feet, and these were associated with pustules. There was no icterus, clubbing, cyanosis, or pedal edema. Cardiovascular system was normal. Respiratory system and per abdomen, there were no significant findings. On examination of the central nervous system, higher mental functions and cranial nerves were normal. Examination of the motor system, attitude in the shoulder showed that there was internal rotation of the arm with adduction and flexion. Elbow, there was extension and pronation, and wrist was in flexion. Hip was in flexion, adduction, and internal rotation. Knee in flexion, and ankle plantar flexion with increased spasticity in bilateral upper and lower limbs. Powers were in the shoulder joint, bilaterally, right side, left side, in all groups of muscles. Power was 2/5. Elbow was also 2/5, and wrist flexion and extension was also 2/5. Hip joint, flexors, extensors, abductors, and adductors were 3/5. Knee was 3/5. Ankle dorsiflexion, plantar flexion was 2/5. Deep tendon reflexes were 3+ bilaterally, involving all biceps jerk, tricep jerks, brachioradialis, knee and ankle jerks. Plantar reflexes were mute. Sensory examination, he he had sensory deficits to crude touch below C4 level. Cerebellar signs could not be assessed. Meningeal signs were absent. Spine and skull, there were no scars or sinuses, no paraspinal muscle spasms. These were the skin swellings that he had, involving the dorsum of the palm, dorsum of fingers, in the proximal and distal interphalangeal joints. He also had swellings over the extensor aspect of the forearm and the extensor aspect of the dorsum of the feet and shin. These were some swellings that we had noted in his ear cartilage. A differential diagnosis at this point was polyarthritis with soft tissue swellings with progressive UMN quadriparesis. The differentials that we considered at this point were crystal arthropathy, probably a gout or pseudo gout, rheumatoid arthritis, septic arthritis, reactive arthritis, or pseudo gout. On investigations, his total counts were 10,800 with a neutrophilic predominance. CRP was elevated 49.7, ESR was 68, rheumatoid factor was negative, CPK was 132, uric acid was elevated at 7.8. These are some radiographs where it can be seen that he has extensive joint space reduction and joint destruction involving the metacarpophalangeal joints and proximal and distal interphalangeal joints on both sides. Even knee joint, there is bilateral joint space reduction with degenerative changes that are seen. He also has ankle joints also showed degenerative changes with joint space reduction, and MRI showed destruction of the posterior lamina processes involving C2 to C4 vertebrae. The patient underwent biopsies from the soft tissue swellings, and the biopsies were suggestive of amorphous material with giant cell reaction consistent with gouty tophus. Skin biopsies from the left leg, left elbow and right leg were taken. Our diagnosis at this point was extradural compressive myelopathy involving at the level of C2 to C4, secondary to gouty tophaceous arthritis with a chronic gouty tophi. He also had systemic hypertension and hypothyroidism. Briefly going over the uric acid pathway and how uric acid is generated in our body. It is generated from via the fructose metabolism, but predominantly by the degradation of nucleic acids, mainly the purine. The purine pathway purine pathway involves production of from adenine and guanosine. Monophosphate inosine is produced, which is converted to hypoxanthine, xanthine, uric acid, and in human beings it's excreted in the urine as uric acid. Whereas other animals who have uricase can excrete it in the form of allantoin. Briefly going through some causes of hyperuricemia in patients. There are multiple causes of acquired hyperuricemia, the most common being malignancies, hemolytic disorders, where there is increased turnover of nucleic acids, resulting in increased production of uric acid, mainly hemolytic disorders, myeloproliferative, lymphoproliferative disorders. Other causes can be ethanol intake, intake of cytotoxic drugs, excessive dietary purine intake. It's also associated with chronic renal insufficiency and diuretic intake. Congenital forms where there are some enzyme deficiencies, commonly Lesch-Nyhan syndrome, which is seen in pediatric population with where there's a deficiency of hypoxanthine guanosine phosphoribosyltransferase transferase. But I just put this table up because there are so many other genes that are also involved in uric acid metabolism and transport, which can cause hyperuricemia. Going through literature, there was a comprehensive study of 88 cases was performed where exclusively on spinal gout, and it was Though chronic tophaceous gout as a cause for cervical myelopathy is a rare entity, in this case study with 88 reviewed cases, majority of them were male with an average age of presentation of 51.9 years, predominantly involving the lumbar spine with presentation with back and neck pain and lower extremity weakness because of involvement of lumbar spine. Majority or 61.36% of the cases were treated with decompressive laminectomy, which resulted in improvement of symptoms. This is from study which showed 55%, 62.5% involved lumbar spine and 14% involved cervical spine, and majority of them presented with elevated uric acid and CRP levels. Back to our patient. Our patient was managed for the acute flare. He was treated with colchicine and was started on uric agent, febuxostat. He was transferred to spine surgery where he underwent posterior cervical decompression, and with that his power improved and he is beginning to ambulate. He's still on a wheelchair. He's discharged and reviewed in our OPD. He's doing well and is under follow-up with a PMR. Thank you.
Thank you, Hamsa. That was an unusual case, but started with a typical history, but ended up with some other symptoms. Any questions from the audience? Please.
Just wanted to give you a comment regarding the slide on the differential diagnosis at the end of the history and examination. All the differential diagnoses do explain the polyarthritis and the skin lesions. May not be the skin lesion, but at least polyarthritis. But then this patient also has a serum and quadriceps which are not addressed at all at this point of time. So when I see this patient, the first thing, although there are no constitutional symptoms, the first thing that is coming to my mind is if this patient is having a malignancy, secondary hyperuricemia, and the malignancy has caused a distal lesion in the cervical spine, although cervical metastasis is rare causing cancer. I mean, that's how my thought process went as I was listening to their case. Because turned out to be a destructive tophaceous gout causing cervical myelopathy. But point is, you're not addressed the quadriceps at all at this point. So if you're not able to put it all together into one differential diagnosis, at least address the problem as a second problem and see what are the differences for that.
So Hamsa, my comment to you was exactly the same, because you're looking at what is going to affect the patient the most. And if you go backwards, the fact that he's got a paraparesis is now hitting the most prime importance in addition to others. So just to echo what Amit had said, otherwise we will go in one direction and not look at all of what is affecting the patient. Does it match? It's unusual, yes. I know that being in the unit that we also broke our heads over, could it just be all gout and compression? But each of the signs and symptoms will need a differential. Either they all match as the same disease or different. That's general for all our presentations. I'm glad he's better. Any other questions from the?
Whether the biopsy after the surgery was also consistent.
Yes. Yeah.
That's, I think, you show that, please show it again.
Just to have an understanding of gout, because like everybody I think is pointed out to you, it is very unusual to have gout like this. So whenever you have a disease, one is like to put the clinical differences like Amit pointed out, the syndromic approach to the entire problem, not as individual, just arthritis and things like that. Second also is to know the natural history of disease. Not everybody develops cervical spine gout. So what are the risk factors in these patients that they develop? What are the duration of disease or what predisposes people to develop this? Will help you understand and then apply it to the patient and you'll be able to do it better. Also, like everybody said, like why is this person having a hyperuricemia that is so bad, it's having such a bad disease? Like, what is caused it? Is it paramucoplasty? What is the reason? You need to understand that also so that like, it doesn't, the disease doesn't progress or beyond your control. So you need to do all that.
So well presented, Hamsa. Few inputs into a general approach with patients who have unusual diseases. Unfortunately, because we are a referral center, you will see patients like this. So their own idea of what started it all off will always be the ultimate question, and we are treating each level of symptoms. But otherwise, I know it was a difficult case and everybody had wondered about a malignancy first. So thank you, Hamsa, and we'll go ahead with the next case from medicine 4. It says shingle ready to mingle, and Purvashri will be presenting.
Also, when you come and please load your presentations. Load your
Is there something you needed help? We're going good on time, so if there's any general comments that anybody would like to discuss based on.
please load your presentations before this. You're coming, bringing your phone, and you're accepting this on the phone.
Okay, we're just doing it in the interest of encouraging more people to present and keeping to time and having a discussion that's relevant. I think that's the important part about the meeting. I'm glad to see so many people here, and I think we all go through the process together. Would medicine 5 Abhay be ready? Then we can do medicine 5 first. Is that okay, Purvashri, or it's loaded? Shall we just Abhay, please? So Abhay will be presenting on patent yet perilous. To those who are uninformed, we always use exotic names for disease.